So from where you are today, since this topic is so hot and everybody's talking about it, we just talked to Dave Feldman on the show. Would you be worried about somebody coming in as that kind of lean mass hyperresponder phenotype where they have very low triglycerides, very high HDL, and also have very high LDL? From where you are now, again, not medical advice, you're not a lipidologist. From what you understand about it, would you be concerned?
No. No, I don't think so. I don't think we have any evidence to say that. Dave Feldman, I consider him the expert in this. I just listened to a podcast he was on yesterday. The way I think about this, and if he talks about this very eloquently in one of the talks he did. If you look at the Framingham data, which is the largest longitudinal data set that we have for heart disease in this country, mostly men, unfortunately, but anyway, if you look at that data and specify the things that you mentioned, low triglycerides, high or normal HDL, no weight problems, no hypertension, and no diabetes or prediabetes, your total and LDL cholesterol doesn't matter in terms of your heart disease risk. And that's what he's finding out with the most recent study he did, Dave Feldman, with lean mass hyperresponders compared to people with familial hypercholesterolemia. It seems like neither of those groups have substantial plaque burden when it comes to their coronary arteries, and the plaque burden that they may have does not have any correlation to LDL cholesterol. So the way I conceptualize this is we have a list of risk factors that are much, much more predictive of heart disease. So smoking, right? Far and away, probably the number one. And then after that, you've got diabetes. And then following those things, obesity and hypertension. And then when you look at the cholesterol numbers, triglycerides and HDL, LDL cholesterol is way down that list. And so I look at it like, why focus on this one relatively small risk factor that doesn't have a very strong association if all these other things are much more important? And the vast majority of my patients have many of those other things. So it's almost like missing the forest for the trees to me. Now, I saw a patient the other day who we've been working on things. She hasn't really committed fully to what I want her to do. And she doesn't have diabetes, which is hypertensive. She's got a little bit of weight concerns, and her triglycerides are 150-ish, and her HDL is 46, let's say. And her LDL is 250. And I said, all right, here's your choices. We can keep working on this stuff, and I guarantee we'll get your triglycerides down. Your HDL will be as good or better than it is now. We'll get your weight in a better place, maybe get you off your blood pressure drugs. But if you don't do that, then you probably have to take a statin, right? Because if you're not addressing these other risk factors, yeah, you probably have to do something to reduce your risk, which there may be some evidence for those statin medications in that case. And so everything's individual, right? No two patients are the same. And I definitely don't tell them to do anything without consulting their primary and doing their own research. Because at the end of the day, I'm not a cardiologist. But I think that if we're overly worried about this LDL total cholesterol problem when we've got bigger fish to fry.
Yeah, not a cardiologist, but pretty decent explanation there. Very good.
And Dave Feldman does so much better than I can, but most of his thoughts on this, I think, are on the money, and I think it's much, much more complicated than LDL cholesterol. I use the analogy. Worrying about LDL cholesterol is sort of like blaming the spackle for whatever put holes in your drywall, in my mind, where what happens typically, is my understanding, is the body, the blood vessels in the heart will get damaged from something, smoking, diabetes, high blood pressure, whatever. And it has to come back and kind of fix those damages. And part of that is some platelets and white blood cells, but also cholesterol, among other things. And so the answer to that problem is not using less spackle, reducing your LDL cholesterol. The answer to that problem is stop putting holes in your drywall, right? Yeah. So maybe that's not the best analogy, but it's the best I got.
Pretty darn good. I really appreciate that. Yeah, I was just at Dave's conference a few months ago, the Collaborative Science Conference in Las Vegas, and the thing that really stood out as we were going over some of the numbers and the data and talking a lot about this kind of phenotype and LDL is how predictive the model is. Like you can hear somebody's stats and almost in your head, like kind of think like, oh, I'll bet this guy's LDL cholesterol is going to be X. And sure
Mhm.
enough, like you're kind of close a lot of the time. It's very predictive and just seems that like the evidence is just getting stronger and stronger all the time.
Yeah, and from a pain standpoint, the way I talk about this is the statin drugs contribute to a number of side effects in many patients, and it's higher than we realize for a number of reasons. But I mean, a proportion of my patients get muscle aches and pains, joint aches and pains. It can contribute to liver dysfunction, cognitive decline. It turns out our brains need LDL cholesterol to transport cholesterol and fats to it to repair itself. Our brain is and our nervous system is substantially composed of cholesterol and fat. Um, you know, Ironically, statin drugs contribute to the development of insulin resistance in some patients, which I find ironic because that is a much bigger risk factor for heart disease than LDL cholesterol is. And so I make sure patients know that risk. And I've seen some people, they come off the statin and their knee feels better or their back feels better because they don't have as much muscle pain. So I'm careful about that. Like I say, I make sure that we're trying to reduce every other risk factor that we can while we do that. But it may be a contributor to problems for people.
I don't think we talk about that enough. I don't think enough people understand the impact of these side effects. And
Mhm.
everybody knows that there's side effects, but there's sometimes you don't realize the impact of some of these things and how it really merits you to like sit down and really think like, do I want to take this and hopefully have this one thing that has really weak evidence and hope that that helps me
Yeah.
versus all these other things that are like day-to-day quality of life stuff. Like I don't think we talk about that enough. That's really important. The cognitive decline piece alone is huge.
Right. Yeah, and you're right. The evidence for primary prevention for the statins is not very good. If you're trying to prevent a heart attack the first time around, the data is something like the number needed to treat, meaning the amount of patients I have to treat in order for one patient to benefit from a statin drug is something around 100. So just about 1% of patients will get some sort of benefit. And typically that benefit, the magnitude of that benefit, if you look at the data closely, is a month or two you delay a heart attack by. And so, again, that's not everybody, but that's just the averages, the way that I understand them. And, you know, Meanwhile, you've got this propensity for side effects.
Yeah, that number needed to treat is so important to talk about as well. I've heard numbers all the way up to like 229 or something like much higher than that. And at this
Could be.
conference, there was a cardiologist who was arguing like, no, 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 it's much better than that. We think the number in certain situations is closer to 1 in 24. And that's a much better number for sure. But when
Mhm.
you think about that, like the point that I made is like, okay, great. Let me grab this guy after he's done talking. Let me see if I can borrow $100 and take it to the craps table out of the casino, out of the conference center, and place a bet on a 1 in 24 probability. Do you think you'd be willing to
Right.
do that? Like, you really need to think about those things.
Yeah, and if you think about that, that's still a 4% responder rate. It's not very good. And so a couple of things. The other part about that data is that many of my patients are on like low dose statins, so they're on atorvastatin 10 or some other low dose statin drug, and most of the studies on statins have been on high dose statins, so atorvastatin or Lipitor 80 milligrams. And so, if there's a dose response to this, the low dose statins are even less likely to help somebody. So again, I don't want to get out of my lane with this. And I'm not trying to say LDL cholesterol means nothing at all. However, I think that we've overemphasized it at the expense of some of these other things, and at the expense of side effects.
Yeah, I appreciate that. And the work of Dr. Nick Norwitz is proving that there's other things you could include in your diet, including Oreos, that might drop your cholesterol way more than a powerful, strong statin. I love that he is kind of pushing that message along in that way, not telling people to eat Oreos, but just showing that this is the mechanism and it's matching the things that Dave Feldman has been talking about for all these years. So I appreciate
Right.
that. I understand it's not really in your league, but I think statins are really important to talk about and all those side
Mhm.
effects, including pain. And as we're getting back to the topic of pain, I
Mhm.
don't think many people make the connection between diet and pain. So let's kind of go there next. Like, how, in your opinion, how is the diet linked to increasing or decreasing pain?
Yeah, so there's a lot of ways that I think this happens. I get patients that come in a couple of varieties. I got some that have definitive structural problems, whether it's, pinched nerves in their spine, terrible knee arthritis with no, joint space left, or hip or shoulder, rotator cuff problems, whatever. And so I think of that sort of like a fire burning in their body almost. And having poor diet and usually some components of metabolic syndrome, right? Insulin resistance, diabetes, hypertension, all the things that we've talked about, it's like akin to somebody throwing gas on that fire. And so if, yes, we can do some things about the structural problems, right? I can do things for pinched nerves in your spine. I can do things to help the pain in your knee. But if we can just stop throwing gas on the fire, you're going to feel better without me touching you with a needle, without me giving you a pill. And in fact, we might get you on less pills. And so, I think there's a couple of mechanisms behind which, dietary influences affect pain. Inflammation is the first one that I talk about. Consistently, people with metabolic syndrome especially have high inflammatory markers. And if you improve that, especially with a low carbohydrate approach, those come down. Nerve function, like we talked about, all chronic pain is in some form nerve hypersensitivity, which happens over time. If we can stabilize nervous system tissue by either stabilizing its signaling in the form of almost like a seizure treatment, there's really good evidence coming out now that improving mitochondrial function by improving energy utilization in the nervous system tissue is one of the mechanisms that nerve function improves, especially in the brain. Improving those things can improve the experience of pain. Weight, we talked a little bit about weight. Mechanically, if you've got a knee problem and you're 60, 70 pounds overweight, we know that 1 pound of weight lost or gained is about 4 to 5 pounds of strain off of those joints. And then, you get into the more esoteric things like mood or mental health. So chronic pain and mental health disorders are inextricably linked. So many of my patients will suffer from depression or anxiety. And if you improve one of those things, the other will improve. Meaning, if somebody suffers from depression and I improve their pain, sometimes their depression gets better. But if I improve their depression, sometimes their pain gets better. And what's interesting about the dietary strategies, low carbohydrate, carnivore, coming out of Dr. Georgia Eads' work, is that it affects both. Meaning, we can improve your mental state, depression, anxiety, schizophrenia, bipolar disorder, and simultaneously also improve the experience of pain from the other side. And so I think there's tremendous power in that in a way that, again, doesn't involve risk very much.